Hey gang, it's Aaron Reed again with nursemastery.com, and today we're going to talk about common code drugs. And I'm going to go over the 8 most common drugs that are used during a code situation. So we're going to do the quick and dirty. We're going to talk about indications, mechanism of action, classification, and adverse effects as well. So let's start off talking about adenosine. Adenosine is an antiarrhythmic that's used for narrow complex supraventricular tachycardia. So this is a drug that you're typically going to use when the heart rate is over 150 beats per minute and when vagal maneuvers have already failed. So you may have asked your patient to bear down, you may have asked them to cough. If they're on a ventilator, you may have suctioned them through the endotracheal tube, or you may even have attempted a carotid massage if you're brave enough. And what adenosine is going to do is it's going to slow conduction through the AV node to lower that heart rate so that we can get a good ventricular fill and get our cardiac output back to where it was. Because if this goes on for too long, we're going to have ischemia of our peripheral tissues. So we're going to start off with 6 milligrams IV push. Now the 6 milligrams IV push needs to be followed by a flush of 10 to 20 mils of normal saline. And the reason that we need to do that is because the half-life of adenosine is only 10 seconds. So if you push that through a peripheral IV and don't flush it, there's a chance that it might be metabolized by the time that it reaches the heart. So the flush is very important. Now the patient may experience chest pain once this has been given. So sedation is advised, or at least a stern warning for the patient. Because what this does is it essentially resets the clock in the heart. So for that brief period of time when the heart stops, that patient's not going to be enjoying it very much. So warn them or sedate them. If the first round doesn't work, you can follow that up with 12 milligrams with a flush, followed by another 12 milligrams with a flush. So 6 milligrams, 12 milligrams, and then 12 milligrams. Again, this may cause chest pain, flushing, and another adverse effect is bronchoconstriction actually. So be prepared to deal with all of those. The next medication that we're going to talk about is amiodarone. Now amiodarone is an antiarrhythmic. It's used to treat ventricular tachycardia and ventricular fibrillation that's unresponsive to several rounds of shocks. So it's used when cardioversion has failed and defibrillation has failed. When the first-line drugs like epinephrine and vasopressin are not working and you're left with not much else to do, amiodarone is a nice backup for weird rhythms that have been, unresponsive to any other measures. So what you'll start off with is a 300 milligrams IV push followed by 150 milligrams IV push if there was no response to that initial dose, or if there was no conversion to sinus rhythm. After that, if you have gotten a response and you're moving forward post-resuscitation, you can begin a drip at 1 milligram per minute over 6 hours. And when that 6 hours is up, you're going to have to shift it over to 0.5 milligrams per minute over the next 18-hour period. So that's 24 hours to lock that patient out of their arrhythmia. Again, this is not a first-line treatment. This is for very unresponsive arrhythmias. Now, the one thing that you need to remember about this is that it should be mixed with D5W only, and that an inline filter needs to be used at all times if you plan on using this as a drip. Moving on to atropine. We're probably all familiar with atropine. It's an anticholinergic, which means that it increases the heart rate. It's very, very potent. It's used for symptomatic bradycardia. Symptomatic bradycardia is usually seen with a heart rate of less than 60, but usually less than 50 beats per minute. You're going to see hypotension, possibly chest pain, possibly lowered level of consciousness, and that's what we mean by symptomatic bradycardia. There's other symptoms that accompany it. You're going to get 0.5 milligrams to 1 milligram IV push every 3 to 5 minutes for a total maximum of 3 milligrams over the course of your resuscitation or your code. This is used followed by transcutaneous pacing if the patient is unresponsive. There's other medications that we're going to talk about later on that are also inotropics that work on other receptors as well that can be used after atropine if it fails. But first we're going to start with atropine. Our next med is calcium chloride. Now calcium chloride should also sound familiar. It's an extracellular ion. It's very abundant in the body. Calcium chloride is used to prevent fatal arrhythmias that are associated with either hypocalcemia or more commonly hyperkalemia. Hyperkalemia can happen for a variety of reasons, either exogenous sources, renal failure buildup, or acidemia, All these different things can cause the potassium to rise, and when the potassium rises, the transmembrane potential in the myocytes, which are in the myocardium, the muscle of the heart, it changes the transmembrane threshold. What you're going to see is peaked T waves, and these peaked T waves can eventually lead into widened QRSs and cardiac arrest. So when it comes time to use calcium chloride, there may be something very wrong. So what we're going to see when we use calcium chloride is we're going to see a return of the resting membrane potential. It's going to increase towards baseline, so it's going to become less negative. That's what the calcium is doing. Okay? And when that happens, the cardiac myocytes become more excitable. Before they were dampened because of the extra potassium, but with this added calcium, we're going to help them to beat more efficiently and more often. Okay? So what we're going to do is we're going to give 1 milligram calcium chloride IV over 10 minutes. Not rapidly, but over 10 minutes. Warn the patient or be prepared for hypotension and bradycardia. Calcium chloride can also be used when you are resuscitating a trauma patient that's had a lot of blood products. It may be suffering from citrate toxicity, coagulation disorders. Calcium chloride is a very versatile drug, and it should definitely be part of your armamentarium going into a code situation. Dobutamine is the next drug that we'll be talking about, and it is an inotropic agent. And when I say inotropic agent, I mean that it works on beta-1 and beta-2. Now, beta-1 activity or receptor activity encourages the heart rate to increase and the contractility to increase. And when we talk about contractility, we talk about inotropy, and when we talk about heart rate, when we talk about contractility, we talk about inotropy, and when we talk about heart rate, we talk about chronotropy. So both of those are going to be hit or activated by beta-1 activity, which dobutamine, which is the receptor that dobutamine occupies. It also occupies beta-2, and beta-2 helps with bronchodilation. Beta-2 also activates vasodilation of skeletal muscle, tissue, veins, and arteries. So you might see a little bit of a drop in the diastolic blood pressure. But really what we're shooting for is that bronchodilation. We're looking for that chronotropy, which is an increased heart rate. We're looking for that inotropy, which is increased contractility. And it's also going to hit alpha receptors. Now, alpha receptors are going to constrict the peripheral vasculature. So they're going to increase PVR, or they're going to increase systemic vascular resistance, PVR, SVR. We're going to use those interchangeably, basically to say that the blood pressure is going to increase, which is extremely valued during a shock type or code type situation. So the rate that we're going to use is 2 to 20 micrograms per kilogram per minute. This is not a drug that we bolus, always used as a drip, and we need to titrate it to response, because we need to be aware that if we overdose a patient, they're going to experience extreme tachycardia or extreme hypertension. Both of these situations place a lot of stress on the myocardium. When you're placing stress on the myocardium to either beat harder or to beat against an increased peripheral vascular resistance, the oxygen demand increases, creating ischemia in the heart tissue, possibly creating an infarct. So we don't want to be the ones that create an infarct. We want to fix an infarct that a patient comes to us with. So always be mindful of titrating to effect when it comes to inotropic agents. Now the next inotropic agent that we're going to talk about is dopamine. Dopamine is used in drip form for symptomatic bradycardia, or when atropine fails, or during post-resuscitation measures when we need to elevate our blood pressure or our heart rate once we've gotten a decent rhythm back. All right. Now the literature no longer highlights its renal vasodilation effects, but some still believe that they do exist, so it's worth mentioning that low-dose dopamine at a low rate will help to increase blood flow to the kidneys, which, after a low blood pressure shock-like situation, can be very valuable to avoid tissue damage and ischemia. We're going to see beta-1 adrenergic effect, and we're going to see that alpha adrenergic effect as well. We're going to start this at a rate of 10 to 20 micrograms per kilogram per minute. Again, this is not a bolus type drug. This is something that we want to start post-resuscitation measures and when other measures have failed to increase the heart rate or increase the blood pressure. Okay, so we're going to titrate to response, because if we give too much of it, we're going to see tachycardia, and we're going to see increased myocardial demand, ischemia, possible infarct, and that's a situation that we do not want to be responsible for. The final inotropic agent that we'll be covering today is epinephrine. I think everyone's familiar with epinephrine. It's really the all-star of code drugs. It's used in a lot of different situations. It's a very versatile drug. It's a hormone found in the body, secreted by the adrenal medulla. It is the code drug of choice typically. It hits alpha and beta adrenergic receptors, so that would be beta 1 and beta 2, as well as alpha. It's used in a lot of situations, including pulseless arrest, bradycardia, ventricular tachycardia, ventricular fibrillation. Now, the main purpose behind this drug is essentially to increase our blood pressure. So it vasoconstricts, but also increases cardiac output through beta adrenergic stimulation. Now remember, beta adrenergic stimulation increases heart rate, contractility, and it also increases conductivity through the AV node. So used in a lot of different situations. We're going to give it IV, we're going to give it IV push, 1 milligram every 3 to 5 minutes during the arrest, or with VTAC and VFib. This dose can be substituted with vasopressin 40 units, which is another very popular code drug that we'll be talking about later. If this will be used during post-resuscitation measures, we're going to give it in drip form at 2 to 10 micrograms per minute, and it's mostly indicated for bradycardia during situations like that. Again, we're going to look at increased myocardial demand and be very careful with how we titrate. The last drug that we're going to talk about is magnesium sulfate. Magnesium sulfate is also an naturally occurring electrolyte inside the body, a lot like calcium. However, in this circumstance, it's going to be known as an antiarrhythmic. So this is used in polymorphic ventricular tachycardia or torsades de poids, which can be used interchangeably. Torsades de poids is a situation having to do with chronic alcoholism, malnutrition, and resulting hypomagnesemia, which then causes polymorphic ventricular tachycardia or torsades de poids. This is used to slow the rates of the SA node impulse. It's going to be given at 1 to 2 milligrams IV. It may cause a decrease in blood pressure. We also need to be careful that it doesn't build up in situations of renal failure, because magnesium is definitely capable of doing that. All right, you guys. So the last drug that we're going to talk about is vasopressin. Now, vasopressin can be used to substitute the second or third dose of epinephrine. Vasopressin is also a naturally occurring hormone in the body. It is in the body. It functions as an antidiuretic hormone. It is going to increase peripheral vascular resistance. Again, it's going to increase blood pressure. It's given 40 units per dose as a substitute for epinephrine throughout the ACLS protocol. So those are the code drugs that are essential to your knowledge base and of which you'd like to be very knowledgeable about moving forward. So for more information, again, you can always visit nursemastery.com. You can visit our Twitter, Facebook, YouTube page. You can check out my ebooks on Amazon, and you can check out our upcoming app called NCLEX Review. Over 1,000 NCLEX review questions in NCLEX format simulation. So thanks for joining us. We'll talk to you later.